Welcome. Thank you for joining this evening's presentation entitled Schizophrenia, an Orthomolecular Approach to Rebalancing Brain and Body Chemistry. I'm going to begin by introducing our presenter. Dr. Albert Mensah is an internationally recognized physician specialist in metabolic treatment approaches for patients with developmental, behavioral learning, and mental health issues. He is the president and co-founder of Mensah Medical, a biomedical outpatient clinic of physicians and nurses who encompass the best of traditional medicine and natural medicine based on biochemical evaluation, evidence-based research, and clinical experience. Dr. Mensah utilizes a non-drug nutrient approach targeted to correct biochemical imbalances that may be associated with anxiety, fears, autism, ADHD, learning disabilities, eating disorders, bipolar disorder, depression, school phobias, mood swings, aggressive or violent behavior, childhood and adult schizophrenia, Alzheimer's disease, and Parkinson's disease. Patients can be seen at our main clinic located just outside of Chicago and in select cities at our U.S. outreach clinics located near San Francisco and Los Angeles, California, Annapolis, Maryland, and Scottsdale, Arizona.
Thank you very much, Dana, and welcome to everyone who's listening to this webinar this evening. Thank you for joining. I just wanted to say that before we actually begin, those of you who've heard me speak before are pretty well aware of my level of skepticism for almost any field of medicine. Usually a lot of proof is required, and still then we have to think about it a little bit from my personal perspective. When I was talking to Dana about different topics for webinars, it came across that schizophrenia as a topic was one that we simply had not done as of yet. I found this very, very ironic because it was this very topic that brought me into this field and kept me in this field. Seeing was believing, and when I saw people who had the diagnosis of schizophrenia actually lose their diagnosis, go back to work, and go back to school at this particular treatment center, I was simply dumbfounded. But, you know, seeing is believing. And I simply could not deny what I had seen, and that's why folks are still in this field. So for the real irony of the situation, it's one of the later topics that we're actually doing seminars and webinars on, as opposed to probably what it should have been, which would have been the first one for me, because that was the one that was so significant and so powerful that I simply had to find out more about this field. So I just wanted to share that with you, and let's begin our webinar. Overall, we look at cases of 10,000 behavioral patients, 5,600 patients diagnosed with ADHD, 3,500 patients who were diagnosed with schizophrenia and bipolar disorder, 3,200 patients with depression and anxiety, and 6,500 patients who have the diagnosis of autism. Well, the incidence of schizophrenia is approximately 1% of the entire world population. That's quite a few people. Inherited predispositions show basically greater than a 50% concordance rate in identical twins. Typical onset of this particular disorder is somewhere between age 15 and 26 years of age. We see a higher incidence in Northern Scandinavian and Western Ireland individuals. Now, there are still some misconceptions that are in mainstream psychiatry, and folks, I just want to say for any psychiatrists out there, in my specialty, we work a lot with psychiatry and have done so. That's part of our formal training. So we have been there, and we still continue to do some of that in certain ways with pharmaceuticals in a slightly different realm. But tonight we're talking about the biochemical side. So I feel free to be able to say that in mainstream psychiatry there are misconceptions. Firstly, there's a failure to recognize that schizophrenia is an umbrella term given to several different mental disorders. We used to think that schizophrenia was one disorder with many different manifestations. Some people were paranoid, some people were this, some people were that, but no. They're not all the same. These are actually different disorders that have been termed or given the term under one particular category known as schizophrenia. The central belief is that there's excessive dopamine activity and or low glutamate activity at what we call the NMDA receptor. Now, this receptor is located in the brain, and its job is to create basically a cascade of activity that leads to certain thought patterns or behavioral patterns. Atypical antipsychotic medications have been the treatment of choice, according to mainstream psychiatry, for schizophrenia most recently. Present schizophrenia theories. There's been the dopamine theory involving the glutamate receptor, oxidative stress theories, epigenetic theories, and virus theories, or that is, the idea that schizophrenia comes from a viral insult. There are several flaws in present schizophrenia theories. First of all, these explanations are kind of weak with regard to the mental breakdown event and why the disorder doesn't go away after the breakdown is done. Also, there's a failure to explain why schizophrenia runs in families. However, it violates classic laws of genetics. Our database from the Walsh Research Institute of chemical studies of greater than 25,000 schizophrenics by Carl Pfeiffer and Dr. Walsh, we see over 1 million chemical assays of blood and urine. We see very high maladies compared to the general population. About 50 to 150 symptoms, traits, and physical characteristics were recorded for each patient and research subject. The symptoms and traits associated with specific chemical imbalances were identified. Biochemical classifications of schizophrenia were developed. Let's look at some of the biochemical classifications of schizophrenia. These are what we call biotypes. In other words, a new system of classifying these so-called disorders that were lumped under the one term schizophrenia. They represent actually very different disorders, each with unique neurotransmitter imbalances and symptoms. Now, understanding, folks, that these unique neurotransmitter imbalances are present means that our other theories, the previous theories, the dopamine theory, they can't possibly all correspond to all these different cases of schizophrenia because the symptoms are different and the chemistries are different. Let's just go down the list. About 45% of individuals who were termed with schizophrenia in the studies were overmethylated. About 18% were undermethylated. 27% actually had pyrrole disorder as a causative agent, or as a causative phenomenon. And pyrrole disorder is actually a reflector of severe oxidative stress. Now, minor or less frequent categorizations include wheat and gluten intolerance as actually the cause of a person's breakdown, and that's about 4%, with 6% being an honorable other category involving things like metals and so forth. Here is our pie chart. You can see in the blue area the 42% that would be overmethylation. The red area represents the 28% that would be undermethylation. And then we see here pyrrole disorder being roughly about 20%, and then gluten intolerance and other representing 4 and 6% respectively. And some of these numbers have been updated in this particular slide, so don't be confused by the previous numbers quoted. Other forms of schizophrenia included those that were caused by a thyroid deficiency. So we do actually check the thyroid when it comes to seeing patients who have this label. Cerebral allergies also come into play as minor possibilities here. Let's not forget drug-induced schizophrenia of a variety of natures, sometimes pharmaceutical, sometimes illegal drugs. Homocystinuria and porphyria, actual biochemical conditions that can also produce schizophrenia. Let's talk about the critical role of methylation. Excessive and deficiencies can actually disrupt methylation pathways in the brain. Let's explain. The body's methyl groups actually turn genes on or they turn them off by affecting interactions between DNA and the cell's protein-making machineries. So It's as though we take a map, a blueprint, if you will, with genes, and then we have these markers or flags. And there's a machine that comes along and reads the placement of these markers or flags, and that's what tells the machine what proteins to make. Those actual markers can be shifted. Now, too much or too little of very important methyl groups can cause a methylation imbalance. More than 60% of anxiety, depression, and psychosis patients have a very serious methylfolate imbalance. The brain is a biochemical factory, and anyone who's heard us speak or tuned into many of some of our webinars have heard us say this several times. Neurotransmitters and neurological inhibitors such as serotonin, dopamine, and GABA are critical to brain function, and they are made in the brain. They're not just coming into existence fully active. They have to be activated as well as inactivated. Serotonin, dopamine, and other neurotransmitters are made in the brain from vitamins, minerals, and amino acids. Folks, that's very important. A lot of us who are in the medical community forget that these neurotransmitters are heavily influenced in terms of production by things like amino acids and vitamins. Yet at the same time, poor us in this field, thinking that we can use those same elements to actually help repair dysfunction in the brain. And that's where orthomolecular medicine comes in. We also see that there's a genetic or an epigenetic imbalance in a nutrient, and that can actually alter brain levels of key neurotransmitters and result in abnormal brain chemistry. By understanding the biochemical biotypes in schizophrenia, advanced nutrient therapy really looks to try to rebalance an individual's unique brain-body chemistry. Let's look at the biochemistry of the overmethylated schizophrenic. Typically, what we'll see is excessive methylation of DNA and histones. Folks, histones are actually coiled pieces of DNA that are not open yet to being expressed, so the machinery can't read that DNA. We see also suppressed genetic expression of dopamine transporters, that's DAT. We see excessive dopamine activity, and we see high oxidative stress. Now, folks, keep in mind, this set of symptomatologies and progressions is for the overmethylated schizophrenic, those with lots and lots of methyl in the system. This is one of the most common psychiatric diagnoses relative to paranoid schizophrenia. Let's look at the traits and symptoms of the overmethylated schizophrenic. Now, folks, there are going to be some overlaps here between some of these symptoms and other biotypes, so we'll kind of move through them a little bit more rapidly. But certainly auditory hallucinations, high anxiety and panic attacks, hyperactivity, low libido, religiosity, tendencies to be overweight, nervous legs and pacing, severe mood swings, dry eyes and dry mouth, postpartum onset of psychoses, that's a very important one, after giving birth, paranoia, depression, sleep disorders, ringing in the ears or tinnitus, upper body, neck, and head pain, hirsutism. Now, folks, just because you've got hair in your arms does not mean you're going to be a schizophrenic, so let's kind of move that out of the way there. Many of these individuals are also very artistic or have great musical ability. Some of them can be very obsessed. There's oftentimes an absence of seasonal allergies. And then there's frenetic activity. And I want you to understand also now, many of these symptoms outside of the paranoia and so forth can be signs of simple overmethylation. But now when we combine overmethylation to the condition of schizophrenia, we see a blending of these and an exacerbation of certain other symptomatologies. Treatment for overmethylated schizophrenia. Well, first, after an initiation of nutrient therapy, are fairly troubled during the first 3 weeks of treatment, but then there's clear improvement, usually beginning around week number 4. Generally, certain medications can be very effective for these individuals, including risperidone and geodon. There's certain SSRI antidepressants that really should be avoided in these individuals, And antihistamines also must be avoided. Now, let me speak to one thing with regard to Risperdal and Geodon. Because of what we've seen from studies from Canada, actually 2 or 3 consecutive studies have shown that long-term use of these 2 particular drugs can indeed produce shrinking of the brain and therefore change the true capacity to fully recoup the individual back to a normal state. So we have to be careful about the length of time we're using them. And that's why orthomolecular medicine becomes so important in terms. Let's look at the biochemistry of the undermethylated schizophrenic. Here we see an elevated blood histamine. Elevated blood histamines are really a reflection of methylation, and there's a sort of the opposite relationship here. So with an elevated or a high blood histamine, we see low methylation. One can also test for elevated absolute basophils, which are white blood cells that contain lots and lots of chemical release cubules, if you will, of histamine. We see, therefore, once again, undermethylation, and we see low ceruloplasmin. Now, many of these patients have had a prior diagnosis of schizoaffective disorder or delusional disorder. Let's look at some of the traits and symptoms of the undermethylated schizophrenic. Severe delusions, obsessive-compulsive behaviors, social isolation, anxiety, a calm demeanor, catatonic tendencies, phobias. Now note, a very high libido, as opposed to the overmethylated schizophrenic, who tends to have a lower libido. High accomplishment before onset. Indeed, how many of us have not seen individuals whose typical story was that they were in a graduate program, a PhD program, a law program, and that's when the trouble began? So we tend to see very high accomplishment capacities in these individuals. They oftentimes are in denial of their illness. There's a history of perfectionism, and that perfectionism is really sort of the driving force that leads to high accomplishment. There's also a very low tolerance for pain. There's a very strong capacity for addictive behaviors. They can be very strong-willed individual. Physically, they tend to be more slender. Oftentimes, there's a prior diagnosis of or oppositional defiant disorder. Cognitively speaking, these individuals can also complain of frequent headaches. Families may note ritualistic behaviors. They may ruminate a lot about past events. And sometimes they sort of have just a blank-minded sort of appearance. Treatment for the undermethylated schizophrenic, once again, after beginning nutrient therapy, undermethylated patients usually report little to no progress over the first 4 to 6 weeks, and then experience a very gradual recovery over the course of the next 6 months. So note, what we're saying is that statistically, the undermethylated schizophrenics take a much longer time to recoup their normal course than the overmethylated schizophrenics do. Now here we've got a combination of biochemical testing, physiological evidence, and all corresponding and correlating within the very specific categories of overmethylation and undermethylation, including noting how the time frame for improvement is different between the two. Now, that also goes to support how these are very different conditions, and they're not just one giant umbrella concept known as schizophrenia. Generally speaking, effective medications that are used, when they're used, include medications like Zyprexa, Seroquel, Abilify, and Clozaril. Many of these patients tend to report a return to a normal life. Let's talk about the biochemistry of the pyrrolic schizophrenic. First of all, we use a urine test in which we assess cryptopyrroles or pyrroles, and we'll find elevated urine pyrroles. We'll also note within the chemistry here, the biochemistry, there are severe deficiencies in zinc. Oftentimes, most of the time actually, we see severe oxidative stress. We also note a very low arachidonic acid level, and this is why, folks, you don't want to give these people omega-3 fish oils. This is the exact wrong way to go in individuals who have pyroluria in general. We also note a biotin deficiency. Now, in all honesty, We don't know why the biotin is low. But what we do know is that where there is pyroluria, biotin tends to be low. We're not yet sure the true significance why yet. The traits and symptoms of pyroluria schizophrenia. First of all, we see that the syndrome tends to manifest during periods of severe stress. There can be mixed psychotic symptoms, extreme anxiety, social isolation, explosive anger to stress. Now, these are two key things revolving around pyroluria itself. There's morning nausea, severe mood swings, once again a pyroluric trait. There's an abnormal fat distribution, usually seen heavier around the midsection. Now, ladies, don't go around telling your husband, well, you must be a pyroluric schizophrenic waiting to happen if he happens to have a beer belly, okay? It's not really that kind of a case. There's a preference for spicy foods as well. These individuals tend to have sensitivities to bright lights and noise. Once again, that's a pyroluric trait. There's a history of underachievement. In other words, these folks really typically just don't care. Other very interesting things include a fear of airplane travel, tornadoes, and things along those lines. But then again, we can't say that's purely a demarcation for cognitive pathology, because lots of people have those fears. However, these individuals can have obsession, can be quite pervasive. They tend to have little to no dream recall. Oftentimes their skin is a little bit more pale. They have a very hard time tanning. Frequently they have infections, and those infections tend to result from the lack of zinc in the system, which is used to buffer the immune system. These individuals will often have abnormalities in menstrual periods and menstrual cycles. We often see poor wound healing, and we also see poor short-term memory, which is typically attributed to a B6, a vitamin B6 deficiency. Let's look at the treatment protocol or the treatment progression for pyroluria schizophrenia. Patients with pyroluria schizophrenia usually improve significantly within the first 2 to 4 weeks of nutrient therapy, with progress continuing into the 2nd and 4th month. Generally speaking, as far as medications are concerned, the atypical antipsychotics tend to be fairly effective in these individuals when they are used. Benzodiazepines, especially clonopin, also tend to work fairly well. Now, I just want to comment here. Folks, notice all these medications are the medications typically tried in traditional medicine for schizophrenia. And why is that? Well, because when medications were tried in certain individuals, they got a positive response in some people and a negative response in others. And they just assumed, well, you know, it's an idiosyncratic phenomenon, meaning for some reason, which we don't know of, it's going to work well in some people, but not others. Well, folks, here is the biochemistry telling us why these particular meds work in these particular categories. Once again, emphasizing that schizophrenia is not one particular disorder. It is several different disorders that has been erroneously given one. Now, one little note I want to make here. Medication support can actually become unnecessary after pyrrole disorder is corrected in these particular categories of schizophrenics. That's a big statement. I know a lot of people out there are going, wow. Some of the doctors out there are going, And believe me, docs out there, if you want to call me and talk about it, we can certainly do that. Gluten intolerance. 4% of psychosis cases are about gluten intolerance. There's an incomplete breakdown of gluten proteins in the GI tract, the gastrointestinal tract. Short peptides are formed with opioid-like properties. They go to the brain and they cause inflammation. The treatment is dietary avoidance of wheat, oats, barley, and rye. What a blessing it would be if more of these cases were actually related. This could be avoided. Let's talk about oxidative stress for a minute here in schizophrenia. All the major biotypes of schizophrenia involve severe oxidative stress. What happens when we have severe oxidative stress? Well, oxidative overload is going to deplete glutathione, and it also reduces glutamate activity at the NMDA receptor. There's very clear evidence of brain cell loss in schizophrenia, and that loss is due to oxidative stress. Now, we see that in the archives of general psychiatry, January 2006. All the doctors out there, feel free to look it up. Here we have actual evidence that's being shown in a mainstream psychiatric journal. Now, here's the very interesting thing. Aside from treating or working at the neurotransmitter receptors, many of these antipsychotic medications that we use have very strong antioxidant properties. So what's happening here is that, remember, with schizophrenia and severe oxidative stress, we're depleting ourselves in general of many powerful antioxidants internally, like glutathione. Now we're seeing that it's not just that the meds that we use have actual neurotransmitter effectiveness, but they're also helping to undo what the oxidative stress has done in terms of depleting glutathione and other antioxidants by they themselves behaving in an antioxidant fashion. That's a very important concept, because that may be part of the true success for many of these antipsychotic medications like Risperdal. Let's talk about the Walsh theory of schizophrenia, also known as the epigenetic theory of schizophrenia. In his evaluation of studying the brains of schizophrenics is an abnormal methylation process or an oxidative overload. We have, for example, cases of sudden onset of schizophrenia after apparent normalcy. Well, why is that? How did it just happen all of a sudden? Even more interesting, after the condition has begun, why is there this ongoing persistence? If the insult caused a problem, shouldn't the problem resolve on its own after the insult is removed? But it doesn't. We also see a multitude of characteristic symptoms, which we'll talk about a little bit later. We want to also emphasize that when it comes to epigenetics, we are looking at illnesses that can be inherited, but they don't follow the typical laws of genetics. And that's where epigenetics comes in. Let's look at what are the evidence pieces of an epigenetic disorder. First of all, there's an abnormal methylation process, or severe oxidative stress or oxidative overload in more than 95% of schizophrenic individuals. It's one of those two, or sometimes both. There's a relative normalcy in these individuals prior to their mental breakdown, that is, prior to the event that caused it. Then there's the persistence of illness after the breakdown. See, schizophrenia violates the classical laws of Mendelian genetics. So the question is now, when people say, is this a genetic disorder? Well, when we try to assess it, we're seeing that it doesn't quite follow the typical patterns, and that has confused a lot of people in the research world. Let's look at some epigenetic insights into biochemical therapy. Well, when we look at Abraham Halfer, truly a great individual in his book and his work with schizophrenia, he used a lot of niacin and niacinamide, and he had great success with a large portion of schizophrenics. So much so that people today still talk about the use of niacin and will, as soon as they learn a diagnosis, start giving their loved ones lots and lots of niacin. Well, niacin and niacinamide act as dopamine reuptake promoters. In other words, they basically act to remove dopamine from the system. Now, if you're looking at the dopamine theory, what this is saying is that, yes, high levels of dopamine are causing schizophrenia. And so if you want to fix schizophrenia, get rid of the dopamine. If you remember our previous slide, we had more than 40% of schizophrenics, diagnosed schizophrenics anyway, as overmethylators. Overmethylators tend to have high levels of serotonin, dopamine, and norepinephrine running through their systems. So certainly, if you were to give an element like niacin blindly to somebody who had the diagnosis of schizophrenia, you might have a very good chance of seeing improvement, which is what Dr. Hoffer saw. But the question was why, which he didn't have. He happened upon the individuals who had high levels of dopamine, niacin and niacinamide, removed the dopamine by way of stimulating what we call reuptake promoters. In other words, transport molecules that are going to take dopamine from the synapse where the dopamine is active and bring it back into what we call the presynaptic terminal. Okay? Depletion of dopamine. Well, that's all fine and dandy, but does it work everywhere? And the answer is no. That doesn't work in the individuals who are undermethylated or pyrroluric schizophrenics. All right? I won't belabor that point. Methionine and SAMe are serotonin reuptake inhibitors. Folates tend to reduce synaptic activity at serotonin, dopamine, and norepinephrine receptors. Zinc, glutathione, D-serine, D-cycloserine, glycine, they increase work at the NMDA receptor, or they increase NMDA receptor activity. And there are numerous other nutrients that influence neurotransmitter activity and brain function. So what is this telling you? If all of these different elements are affecting different neurotransmitters, different receptor sites in the brain, all within the same category of schizophrenia, how could it possibly be one disorder? There's several different characteristics, several different truly prevalent mechanisms that are different, and that's why you get different treatment protocols that work differently in different schizophrenic patients. Let's look at the future of epigenetic therapies. Deviant epigenetic marks appear to be reversible. That's good news, folks. Future epigenetic therapies may represent the best therapies for not only schizophrenia, but also for anxiety, depression, OCD, and psychosis. Early epigenetic testing and treatment may actually enable the prevention of these disorders. Folks, I'm just going to comment. It's my personal philosophy, my personal belief, that we're advancing so rapidly in this field that one day in the not-too-distant future, children may never be born with any of these conditions. We'll be able to test in utero, look at what the genes and the epigenetics are doing, fix them before the child is ever born. Now that sounds like a whole bunch of science fiction, and I admit it, I'm a big sci-fi fan, but we can also tell you in science that science fiction has been the foothold, the foundational, pivotal key for which much of what we've got today in active life is due to. So bear with us on that one. Comprehensive evaluation. Now let's get back to reality here. Let's talk about how we go through this process. Well, of course, firstly, we must do a physical examination. Then we need specialized laboratory testing. We need chemical analyses of blood and urine in order to have an accurate diagnosis biochemically. We look at the present symptoms, traits, medical history, and the family history of the patient, including symptoms during the initial breakdown, response to any psychiatric medications, because, folks, that response to the medications can actually give us a clue as to what their true chemistry is, whether they're undermethylated or overmethylated or even pyrroluric. Also, the question about the dominance of hallucinations or delusions. Each one of these can, of course, present in certain chemistries but not others. Then there's the issue of psychiatric medication, what has been tried, what has been utilized, where the successes have been, and where the failures have been. Let's look at basically a general overview for treatment. The nutrient therapy program, of course, is the hallmark of this entire process, using vitamins, minerals, and amino acids in order to normalize body and brain chemistry. Okay? Current medications, if somebody's on medications when they come in to see us, we do not remove the medications at that point in time, and we typically work with the psychiatrist at the appropriate time in order to talk about weaning and removal of medications. But the current medications need to be continued at a full dosage for several months, unless, for example, sedation becomes way too excessive. somewhere around month 6 to month 12, after significant improvement, medication dosages may be cautiously reduced to tolerance with the assistance of the treating psychiatrist. Folks, let me say this again. With the assistance of the treating psychiatrist, I've come across far too many patients who have removed themselves off of medications and have had horrific results. Horrific. It is not to be done. It should not be done. It is not a safe thing to do. Let's talk about the long-term, low-dose medication support may be needed to avoid relapse. And note, this is different. I'm saying something different than what the slide is saying here for a reason. Okay? It's not necessarily necessary. Now, in the old days, before the advent of the atypical antipsychotics, the risperidals, the Sericals, the Geodons, we used to actually have a tremendous capacity to return individuals to an to a normal state. Many individuals were working, going back to school, getting graduate degrees after treatment for what was termed schizophrenia. In other words, we treated the chemistry that would underlie the title condition. What we found out most recently is that individuals who have been on these meds for greater than 10 years have a reduced capacity to fully normalize with nutrient therapy alone. So what we now do is that these individuals typically will require some lower dosage of medication support in order to prevent a relapse. However, usually when you lower the dosage that's present, a lot of the other symptoms associated with those medications, in other words, the side effects of those medications, tend to simmer down and they're less severe. Let's look at our outcome studies regarding schizophrenia. 85% of individuals reported that life is better after nutrient therapy. 75% report the ability to actually reduce their medication. The highest efficacy we have is for the overmethylated and the pyrrolic schizophrenic. But it doesn't mean that there's no benefit or not even tremendous benefit for the undermethylated schizophrenic. Most cases recovery. Now that's saying a lot. But once again, folks, the proof is in the pudding, or actually in the patient who's now paying taxes like the rest of us.
Thank you. It is now time for the question and answer portion of the webinar. I'm going to pause a moment while you may enter your questions into the question pane located in your control panel. First question is, please explain why a pyrrolic schizophrenic individual may not be given omega-3 fish oil. The individual is also undermethylated.
Yes. The reason for that is the nature of arachidonic acid and what is actually and how it's being processed in the system. There seems to be a glitch there. These individuals tend to require omega-6 fish oils, or excuse me, omega-6 fatty acids, and things like evening primrose oil as opposed to traditional fish oils. It's about processing in the biochemical system. The system actually gets flipped. You end up with a pro-inflammatory condition if you use omega-3s, and people get worse because of that arachidonic acid challenge. So the omega-6s are typically what's emphasized. Now note, we're not saying that you don't need omega-3s, but there's a very particular ratio of omega-3s, 6s, and 9s that tends to be required in the human system. We tend to get enough omega-3s in general in many of the foods that we eat under the condition of pyroluria, such that it's a much more powerful element to simply focus on the omega-6s and evening primrose oil, because that's where the challenges and the deficiencies are going to be.
Can drugs still induce schizophrenia 15 years after use? And if so, which ones?
That's actually a very good question. I've come to learn that nothing is impossible. However, typically speaking, if a drug is going to induce schizophrenia, it would happen earlier rather than later. Now, if it were to induce schizophrenia, it might be because there would be some type of brain chemical shift that is now affecting genetic expression of certain proteins that make the individual more susceptible to any type of oxidative stress. In other words, it might lay down the foundation for vulnerability to outside stressors. So there would be the combination of variables and factors. In other words, and that could lead to a schizophrenic break. Now, which medications, folks, I honestly can't go there with you, okay, for a variety of reasons, especially legal ones. But I would just say that any medication, any pharmaceutical, any illegal medication could potentially lead to oxidative stress challenges. So just be careful. That's why we're careful about the use of medications and why a doctor is there to help guide you through that process.
My son has some signs and symptoms of both over and under methylation, but not all of either. How do you explain that?
That's a very good question, and that's because there are actually fine delineations. When you're looking at these, in text or online or whatever you're reading, there are actually fine delineations that are brought up by the physician practitioner when they're speaking to you and going through an assessment. Okay, things like anxiety and depression can exist in both under or over methylation. Many of the similar symptomatologies that are present in either condition are really more general than they are specific. In other words, they're not the key elements that are going to delineate undermethylation syndromes versus overmethylation syndromes. They're simply commonalities that can occur, but they're not the ones that tell you, hey, this is someone who's undermethylated versus, hey, this is someone who's overmethylated. That's the other reason why you need absolute testing. Testing is what tells you, is someone undermethylated or someone overmethylated, or are they even normally methylated? You cannot simply read, and this is why it's such an advance from traditional psychiatry. We're not depending on symptoms to tell us what is going on with this individual. We're looking at objective evidence pieces in biochemical testing and analyses, and then we correlate those things with, indeed, the symptoms that a patient may have.
Apparently, Dr. Mensah, you were cut off after you said the highest efficacy is for overmethylators and pyrolics. What is the prognosis or efficacy of nutrient therapy for undermethylators?
For undermethylators, we still see a very good prognosis. They are probably and that part of the reason is because they are the longer ones to respond in terms of overall time capacity. You start to see those shifts really after about 6 to 12 months. And it's very hard for many people to continue therapies when they're not seeing an immediate response. That's that place where we live in this country and in this world where we want immediate gratification. No, this one is about patience. It's like climbing the stairs to a very tall mountain very slowly. And these stairs might be only a few inches tall, and you've got several thousand to go. You will get there, on average. However, it's going to take time to get there. There's still very good results that can be seen with undermethylated schizophrenics.
How do you handle low serotonin, elevated dopamine for an undermethylated individual when methionine raises both serotonin and dopamine?
Individuals who are undermethylated tend to have lower levels of serotonin. So methionine is not going to be so much of an issue with regard to that. Now, I want you to understand also, we're not simply treating neurotransmitters. As a matter of fact, we don't treat neurotransmitters. We treat the overall chemistry. If there's a methylation problem, you can pretty much bet that that is the foundational issue, and that once you fix the domino of methylation, all the other dominoes are going to right themselves. It's not simply a matter of, is this person a high serotonin, high dopamine, high whatever. That's what traditional medicine was doing in psychiatry, and we were not right in those circumstances. So we're not going to focus on simply one neurotransmitter not meshing with what the entire picture looks like, or with which a portion of that picture looks like. We're looking at the entire individual, and that's how we determine which nutrients to use, how much, when, and why. Got to look at the big picture, the whole picture, not just one element.
You mentioned these studies are rapidly advancing treatments and results look very encouraging. Just how recent are some of the studies you've mentioned in this presentation? And before Dr. Mensah actually answers this question, just published in April 2014 was an excellent study that proved that maternal nutrition at conception modulates DNA methylation. And this was an extremely important recent study that provides evidence for Dr. Walsh's theories of autism and schizophrenia onset, namely methylation imbalances in early gestation. So just wanted, if I can, I'd be happy to send you that specific link to that study because that is a very important study. I know you have other studies come to mind for you as well, Dr. Mensah.
The most interesting way I want to kind of put this is that the studies have been progressing and they've been increasing. Many of the studies originally were done 20, 30 years ago, but what we've seen is now evidence is showing up in mainstream journals. The American Journal of American Psychiatry, for example, has had a lot of research on the effects of certain medications and on brain function and neurotransmitter activity. Now, within those same, they're talking about the use of elements like D-serine, D-cycloserine, and sarcosine, which are nutrient-based elements that are actually causing major effect at receptor sites like the NMDA to help improve conditions like psychoses, OCD, etc., etc. There's tremendous volume of information coming out, not just here in the United States, but around the world, including Australia and China. Some of the more interesting articles that we've talked about were certainly from 2006. We mentioned that one here. But the studies are ongoing, and more of them are coming out. Very interestingly, we learned some very interesting pieces about cancer research and methylation from the Journal of Hematology and Oncology, once again a traditional mainstream journal. And that particular piece referenced the role of methylation and DNA cycles in development, which really led to the whole idea of what's going on during embryogenesis, the development of a living embryo. What really fascinated me, I almost have to laugh at myself, was Wikipedia, of all things. I looked at Wikipedia one day, and I saw them talking about the development of the embryo. And what really hit home for me, now they weren't talking about things from a structural perspective, they were speaking biochemically, and what they talked about was the process of methylation, demethylation, remethylation, and then demethylation again as ongoing cycles that occur millions of times a second at every single cellular division in the development of the human being. Now imagine if you proper methyl capacity or the proper methyl to folate ratios at any of those early stages, what would happen? You're not going to get appropriate development. And that was so interesting to me that something as benign as Wikipedia would have that information. So it's out there and it's growing in volumes, and I'm really excited about that, in case you can't tell. Certainly be happy to give you more and more journal articles. If you want to email us, we'll be happy to do that for you.
Let's see. What are the chances of full recovery for someone diagnosed at 8 years old with undermethylated schizophrenia?
I like that. Actually, the younger a person, now here's the very interesting thing. This kind of references childhood schizophrenia. And this concept, I kind of saw this one night at about 3 o'clock in the morning. I hate to say it, I was having an insomniac moment. And there was someone on television who apparently had what was diagnosed as childhood schizophrenia. And quite earnestly, I looked at the behavior of this child and I said, that's not schizophrenia. Those are certain combinations of biochemical abnormalities. We've seen that before. So first of all, I want to challenge the diagnosis. Okay? We may call it schizophrenia. I doubt very seriously that's what it is. my particular perspective, and I'm saying this now, this is me. I'm not saying this is upheld by, any of the mainstream journals or whomever have you, but it's because so many are not aware of the biochemical theories here or the biochemical underpinnings of these behaviors. What I saw in this child on television were behaviors very similar to the kids who've got undermethylation, copper toxicities, or in some cases even overmethylation, combined with zinc deficiencies and a variety of other elements, which could include wheat and dairy intolerances or gluten intolerances. So I really would like to get my hands on a child who's been diagnosed as having schizophrenia because, first of all, I don't believe it. And the reason why is because, now let's just bring this up. Folks, as far as we're concerned in the orthomolecular community and at the Walsh Research Institute and at Mensah Medical, schizophrenia is a term. It is not necessarily the condition. The condition is one of biochemical imbalances that are each producing effects at the level of DNA that change protein production, change neurotransmitter activity, and change a variety of symptomatologies in the human being. One of these abnormalities or groups of abnormalities have been improperly given an umbrella diagnosis. It is not one condition. We typically don't even really like using these umbrella terms. We don't believe these people are so-called schizophrenics or depressives or people with general anxiety conditions. No, these are symptoms. Realistically, we could say that the umbrella term of schizophrenia is more of a symptom which reflects multiple behavioral challenges that are caused by biochemical subtypes. Here's the deal. In psychiatry, these particular terms, schizophrenia, etc., are not curable. So we don't talk about curing schizophrenia. But the question remains, if you fix the underlying abnormalities that as a group lead to the diagnosis of any psychiatric condition, did that psychiatric condition ever truly exist? Now, some of you may be a little bit confused by what it is I just said, and here's the reason why. In psychiatry, we call something a psychiatric condition after we have run every test we know of from an organic perspective and come up with no particular cause that, when treated, produces resolution to that condition. That was the original underpinning of the entire field of psychiatry. Now, back in those days, we didn't have these kind of tests, nor did we have these insights. So today I say to you, are these conditions truly psychiatric? Well, if we treat them and they improve, then the question is, we got to question the question. I doubt it. Very seriously. So, gosh, Dana, I think I went on and on. It's okay if you laugh at me out there, folks. It's okay. But what were we?
Actually, I then got another message to clarify. Her son was diagnosed 8 years ago. I'm sorry, he was not 8 years old. He's now 22 and received a recent diagnosis from you as undermethylated schizophrenia.
Okay.
So what is the potential for full recovery?
The potential, and by the way, I still stand by everything I said. I'm glad that mishap happened, because anyone who's out there who has a child who's been diagnosed with schizophrenia, be careful. You've got to evaluate this child early. It'll save your life, your time, your family's struggles tremendously in terms of improvement. Now, for the older individual who's been diagnosed as an undermethylated schizophrenic, there's still great capacity for improvement. Once again, it simply takes longer with regard to undermethylated schizophrenics. It's not the 2 to 4 months or 2 to 6 months. This can be anywhere between 9 months to a year, sometimes on occasion a year and a half. But what we do say is that there is tremendous improvement, to say the least.
Excellent. So we have a lot of questions on how do you test for over and undermethylation, and can it be tested at home?
Well, we test for over and undermethylation by blood tests. and we look at histamine as a reflective marker of the methylation process. Now, can it be tested at home? The answer is no. This has to be done at an appropriate lab, typically a lab core facility, and we tend to use direct healthcare access to as the lab to coordinate the local lab for you. Unfortunately, no, these things can't be done at home. Not typically.
And what connection do you see with the MTHFR mutations and methylation?
Oh, I was anticipating this question, and I'm going to try to make this. I get this question about 1,000 times a day, so folks, bear with me here. The whole idea of the MTHFR began really in the autism community, and it was actually Dr. William Walsh who brought methylation to the autism world. Before that, they had no idea about it, and from the autism world ultimately evolved this genetic testing called for the MTHFR enzyme. And the idea was that if indeed there was a mutation or two in this enzyme, you would see tremendous difficulty in methylation. So it was assumed that if there was a mutation or two, somebody was undermethylated. Now there are several flaws with this theory and this idea. Okay. Now, before I get into this, let me just say we're cheating a little bit here because we at Mensah have been treating methylation for more than 30 and 40 years. So we know already the end result of using certain therapies for methylation challenges. So when we look at this MTHFR testing, the idea is that it's going to give you an idea about undermethylation. Well, here's the thing. This test is a qualitative test at best. It is not a quantitative test. It doesn't tell you how much or how little methyl is present in the system. It tells you that one enzyme may or may not be problematic in the methylation process. Well, okay, Dr. Mensah, why do you say one enzyme? Why do you doubt the efficacy of this test, etc.? Well, let me tell you. There are between 13 and 15 different enzymes that work in the total methylation process. Dr. Walsh talks about a tug of war between the enzymes that are involved in undermethylation and the enzymes that are involved in overmethylation. It is the sum total of the activity of all those enzymes that determines a patient's status. So methylation, or a patient's methylation status, is not determined by the MTHFR test. It's determined by the activity of probably 15 different major enzymes through 3 cycles of methylation. Okay? 3 different cycles that are all together forming the methylation process, as we call it. So one of the difficulties is that the MTHFR test, that genetic test, only tests for one enzyme. Secondarily, it's not a quantitative assessment. It is at best a qualitative assessment. Now, tertiarily, thirdly, here's another problem. Genetic defects are very significant when you have smaller molecules or enzymes where the defect is present. For larger enzymes or molecules, those genetic defects really don't have quite as much significance. Now, I want you to imagine, wherever you folks are, I don't know if you've been to Chicago or not, but imagine a giant truck that is about 3 blocks long and has about 77,000 tires, if you believe it or not. Okay? If you blow out 1 tire or even 2 tires, the odds of that truck being significantly affected are next to none. Okay? The molecule that is the MTHFR, that particular enzyme, has 77,000 base pairs. When you have or that molecule rather, in that base pair, that's akin to 1 mutation in 1 base pair out of 77,000, which means that you've got 76,999,000 base pairs still working. If you have a homozygous SNP here, where you've got 2 SNPs, that means that, do the math, You've got 76,998 base pairs still functioning. So this is a tremendously large molecule. And even if it gets slowed down, the odds of one SNP or two SNPs significantly affecting methylation are truly, truly not very great. So there's been a lot of misconception about what the real significance of this particular test is doing here. It is not necessarily truly shutting down methylation, or it all depends on what all the other enzymes are doing in addition to that particular one. Okay? So I'm not even going to comment on treatment based upon the MTHFR testing. Right now, I just wanted you to understand the true significance of that particular test. It is possibly qualitative, but it is not quantitative. The blood histamine test, on the other hand, histamine has a very particular relationship to methyl. They're diametrically opposed. Methyl suppresses histamine, and histamine suppresses methyl. So when we see that, for example, histamine is high, it means that methyl is low. This methyl that we're talking about is a quantitative assessment of the sum total of activity of all the enzymes in the methylation cycle. And it's interesting because back in the old days, we used histamine because we just thought it was a great reflective marker of methylation. We didn't understand necessarily the true inner mechanisms revealing why that test was so good. Now, after evaluating, thanks to the MTHFR genetic tests and other challenges, and trying to figure out where all this was really going, and looking at all these other enzymes involved in overmethylation, we see that the test that we originally started with is right now the most functional test we've got to truly measure quantitative methylation in the system. Now, I'm going to stop my treatise on that one because I could probably talk for a very long time on that subject.
Mm-hmm. I've had a few questions on copper toxicity. Yeah. One being my daughter has a diagnosis of schizoaffective disorder. She has high copper. Can copper by itself cause her problems?
Copper can cause a tremendous number of problems. Now, let me just share with you how this happens. And if you think in your mind about a nerve cell, just draw one long, thick string, so to speak, and that's the nerve body. Copper can actually stimulate that nerve body into activity. That particular piece of information comes from a study done back in 1942 using just 5 micrograms of copper in a petri dish with one nerve cell. That nerve cell activity lit up tremendously. Now, let's think about a few billion nerve cells and copper infused into that same system. What you're going to get is dysregulated nerve cell activity, and therefore dysregulated nerve cell communication, and therefore dysregulated behavior as well as cognition and thinking. Now that's just one part of it. Forces dopamine to turn into norepinephrine. So now you've got a neurotransmitter effect by which copper is producing dysfunctionality. So you've got all these erratic nerve cells active and highlighted and moving and doing whatever they do to communicate or trying to communicate. Then you've got the neurotransmitter imbalance with high levels of norepinephrine. And yes, indeed, given just those two variables and nothing else, you can probably have quite a few of the symptoms that schizoaffective disorder might sort of correspond to or correlate to. Okay? Now, I'm not saying that high copper causes schizoaffective disorder. I'm not saying that. But I can tell you that copper in excess can produce impulsivity, mood imbalances, tremendous mood swings, dysregulated thought, and does that already sound familiar? The schizoaffective part is dysregulated thought added to an emotional component, and that can certainly happen with high copper.
My father-in-law has schizophrenia, and my wife has celiac. What, if anything, should I do for my 3 kids to help them not get schizophrenia?
Wow. That's a very interesting question. And truly a biochemical evaluation, actually, of both your wife and your father would yield a great deal more information from a prognostic perspective. It depends on whether your children are normally methylated, overmethylated, or undermethylated. If they've inherited a propensity for gluten sensitivity or celiac disease or anything along those lines, there are a myriad of variables, and quite a few of them can actually be tested, and some level of predictive capacity, or at least insight into how to prevent it, can be given. But unfortunately, the key here is that both families, those two particular individuals, and even you, Dad, would have to be tested along several parameters in order to really give a great answer to that question. Because the question really revolves around what the stress tolerances are, what the epigenetics of your children happen to be, and we simply don't know that without testing. There's no simple over-the-counter mechanism for prevention that way. The one thing I can say, though, is what's kind of key to all aspects of these schizophrenic breaks is oxidative stress. So one thing I guess we could say, I guess I have to retract what I was saying before, one thing we could say is that minimizing oxidative stress would be very important in your children and your family. However, oxidative stress can come from illness, from viruses, from trauma, both emotional and physical. And just in those four categories alone, that's almost impossible to prevent in just the human experience. So the question becomes, what is really your family's susceptibility to oxidative stress? And that's one of those things that would have to be tested. Okay.
My son is an undermethylator. He has been on the nutrient therapy for 3 months. He has a major delusional disorder. In your experience, have you seen the delusions subside, or will you still have to deal with them?
The answer to the first question is yes. And if they subside, he shouldn't have to still deal with them. That's simplistic. The answer is yes, indeed. Individuals have lost those delusions, but usually, once again, it takes time, especially with undermethylators, a lot more time than just 3 months. And then we have to look at what are some of the other potential factors, including dietary regimens, including yeast overgrowth, gut dysbiosis, all of these things, and metal toxicities. All of these things in the environment can contribute to delusional thinking. It may not be just the one thing. So it's a matter of who this individual is as, I hate to put it this way, but a whirling vortex of biochemical and oxidative insults and dysregulation.
How common is undermethylation combined with pyroluria? And what have you seen as far as results with this diagnosis?
In actuality, in individuals who don't have the undermethylation and pyroluria quite frequently, individuals tend to do very well over time in general. Now, with regard to the undermethylated pyroluria schizophrenics, the real question is which of the disorders, which of the biochemical dysregulations is truly the key cause or the prime contributor to the patient's symptomatologies. That's what tends to indicate the time period or the time frame of improvement, and certainly the capacity for long-lasting improvement. Because individuals who are pyroluria, they're extremely stress intolerant, and another stressful event could literally bring those individuals back into a challenged state if they're not continuing or maintaining their nutrient therapy. And I say that because it's a great question, and I do remember a patient that we had, James, who was actually fairly catatonic and was a pyroluria undermethylator. And this individual did extremely well within 6 months. Within 6 months, her parents had her back in graduate school without talking to us first, put her under the same stress that caused the initial break to begin with. And what do you suppose happened? Within 3 months, less than a semester, that individual regressed and went back into that catatonic state. And it's much harder to bring individuals back to a decent place after a second insult because of poor nutrient compliance than it was getting them there in the first place. So yes, indeed, it's possible, but it also depends on which mechanism is the prime mover in that condition. And oftentimes we don't really know that until after we see the timing of the resolution itself.
What is the biochemical imbalance that causes an estrogen intolerance?
That's a very interesting question. And while it's kind of outside of the spectrum of the discussion of schizophrenia, it's not so much a biochemical imbalance that causes, as far as we know, an estrogen intolerance. It's actually kind of the reverse. Estrogen causes the body to produce or to upregulate copper. And it's the copper that wreaks havoc in the system of many females, especially those with cancer, breast cancer, and estrogen receptor positive breast cancers. These individuals usually have higher levels of copper that allow for what is called angiogenesis. Angiogenesis is the process by which blood vessels are made. Now, in any individual, for example, a menstruating female, a female of reproductive years, a female who is carrying a child and growing a baby internally, or an individual who has cancer, any of these conditions require or necessitate vasculature. Indeed, that's how cancer cells grow. They recruit blood vessels and nutrients from the patient, from the person themselves. So that's why estrogen is actually so important and so key in many different conditions. It's not simply the estrogen itself, it's actually the estrogen that's affecting the biochemistry, namely the increase in copper. And in individuals who can't get rid of the copper too terribly well, they tend to come up with and have all these particular challenges, or some of these challenges: menstrual irregularities, anxiety and depression, along with sometimes fibroids, endometriosis, chronic fatigue syndrome, fibromyalgia. All of these can be related to actually copper toxicity. So it's not the biochemical imbalances that lead to the estrogen challenge. It's actually the estrogen challenge that affects the biochemistry, which then affects the rest of the system.
Does your clinic standard testing include testing for gut dysbiosis, metal toxicity, and yeast overgrowth?
The answer is yes, 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 and yes. And then the question becomes maybe. After doing a very thorough history and discussing with the patient the events that led up to the situation, family history, genetic influences, etc., then the determination is made as to which tests we will incorporate and within what timing. Usually we'll do a more stratified approach. In other words, we'll deal with and perhaps a few other tests first. Then we will probably look at the next layer of testing within a couple of months to 3 months. That next layer of testing, on average, if it's not a patient who has autism or some severe allergy to food, that next layer of testing will typically be the things that will affect the gut. So wheat and dairy intolerances, food intolerances, and so forth and so forth. Metal evaluations will often be the third line of evaluation, once again, depending on the particular patient. But the short answer is, after all this verbiage, yes, indeed, we do test for those things, but it's really sort of dependent on the given patient, their condition, which tests we're going to do in what timing.
When you say nutrient therapy, is this something patients buy from you forever, or do you recommend ongoing nutrient therapy we can buy locally? I mean, once your clinic is happy with the results.
Okay. Very interesting point here. We don't do, what we do is we write basically a prescription of a compounded nutrient. So the nutrients are actually put together into basically what is a designer supercharged multivitamin. We don't do that ourselves. We actually have a pharmacy that we work with, and they're the ones that do the compounding. We don't do that. For patients who often are consulting with us, we may recommend very specific and limited nutrients that, because people have a hard time finding, we do carry. But those individuals who are our patients, they actually get a compounded prescription that is sent into a separate entity of which we derive no financial benefit, and I have no monetary investment in, no stocks in that company. And that company is the one that makes the product for them. So there's basically a very specialized formulation that's used that's individualized for each patient, but you can't buy it over the counter. And for now, we have to say, yes, it's an ongoing process of daily utility, one that can't be sort of done by way of buying lots of supplements over the counter. The concentrations are not going to be there. The dosing regimen, the dosages are not going to be there. And quite honestly, quality control is not going to be there over the counter. Okay? And that's a very important issue, because we've seen people have some very challenging symptoms that arose, and we found out that there was lead, mercury, or even arsenic in some of these products, because they were made from certain countries that I'm not going to name, and sent over here as a baseline piece to make certain nutrients that are sold over the counter. Okay? So now, don't get me wrong, there are lots of really good companies out there that produce great products, and I'll name a few that I feel confident in doing. Now Brand, Biotics, Fruitful Yield. A lot of companies are really good companies that make great products, but you're not going to be able to substitute things that are over the counter simply because of sheer numbers, concentrations, and reliability. Not a whole lot of people really want to take 13 or 14 different supplements in the morning, or 3 times or 4 times a day. It's kind of hard to do. So those components need to be put together into individualized capsules, where it's more like maybe taking 3 or 4 capsules twice a day, or maybe 3 times a day at most. Okay.
Oh, can you waver between over and under methylated states?
No.
Okay.
Now, I don't want to sound cheeky once again. Methylation is a state that is hardwired into your DNA. Remember, it is an epigenetic phenomenon where it's actually the program of your blueprint that gets shifted. You do not, now the testing may show something that looks like you're trending for a moment in a different direction. However, you do not change from being an overmethylator to an undermethylator. That's not going to happen.
What do you think of the GAPS diet for schizophrenia? Can you heal schizophrenia through diet, or are supplements a must?
Look at an earlier slide and we talk about the smaller percentages, for example, the 4% who are gluten sensitive or sensitive to some particular food stuff. Yes, indeed, staying away from those particular foods can lead to resolution. But remember, that's only in about 4% of individuals. Okay. Unfortunately, I should say, fortunately, nutrient therapy is available and it's there, and typically it's what's necessary to help bring people back into appropriate balance. Because even if we've got, say, a gut issue or a dietary issue, that presence creates inflammation. That inflammation also goes to the brain, and that inflammation has to be dealt with. Removing the diet or shifting the diet does not change the course of the present inflammatory cascade that is causing the problem. And so you still need to treat with nutrient therapy, at least.
Can heavy metals or bacterial imbalances in children be the cause of these vulnerabilities you describe, or more likely a result of them?
Can you repeat that?
I'm sorry. Can heavy metals or bacterial imbalances in children be the cause of these vulnerabilities you described?
Okay, heavy metals certainly, and that's actually a small percentage of the people who have been categorized as schizophrenia. But what I want to share is that what we're talking about ultimately here is oxidative stress, and quite often it doesn't really. In many cases, the source is not so much the issue. Now, I'm hesitating about bacterial dysbiosis and simply bacterial imbalances in the gut. That's not one that we see very commonly, and I'm very hesitant to even comment on that. My real instinct is that that is not significant relative to the main cause of the schizophrenic insult or occurrence. It might be tertiary, maybe secondary at best, as a contributor, but not the prime mover in this condition. Not the prime mover.
Mm-hmm. What if a person is normally methylated? Are all schizophrenics over or under?
No. Some are pyrroluric, for example, and once again, some are metal toxic and some are food sensitive or have an allergy. So no, over and under methylators, they tend to be together a formidable component of the biotypes of schizophrenia. However, they're not all-inclusive. It's not an all or none for schizophrenics who are purely pyrroluric without any methylation challenges one way or the other. They're normally methylated. They may also be purely food sensitive. They may be purely metal toxic, and methylation status is absolutely normal. Okay? Or I should say within normal limits there.
Can you be an overmethylator by blood test, but be undermethylating due to heavy metals or synapses breaking the methylating cycle?
I'm going to ask you to repeat that one more time for me, Dina.
Can you be overmethylated
Yes.
by a blood test,
Mm-hmm.
but be undermethylating due to heavy metals or synapses, breaking the methylation cycle?
No, you cannot. And the reason is that our testing for methylation involves an indirect marker for concentration. Okay. It is a reference point that is illustrated by actual methyl groups in concentration in the biochemistry in the system. If there were a gap or a challenge in the methylation cycle, we would never see high concentrations of methyl. What we would see would be low concentrations of methyl and therefore high levels of histamine. So no, you cannot have, by our testing, a person who is functionally undermethylated but showing up as overmethylated in the system. Not with our testing. Our testing references the actual concentration. It is a quantitative assessment, not a qualitative assessment.
Mm-hmm. How do we get overloaded with heavy metals? Through eating utensils, vaccine? Is our food tainted with metals by factory environment?
Yes, no, yes, and yes. Exactly in that order. The environment, two variables, two factors here. One is exposure. The other one becomes the idiosyncratic, individual incapacity to process those metals. So it's not just metal exposure. Why is it that people living in, let's just say metropolitan Chicago downtown, or say a heavy industrial area like Pittsburgh somewhere, or some other town in the United States or across the world, why is it some people get affected and others don't? Why do some people get sick and others don't? Being exposed to the same variables. It's the individual person's incapacity to get rid of those toxins. It almost doesn't matter what the source. It's about the person's capacity to get rid of them. Now, we have several methods that help us regulate and remove toxins and toxic exposure elements. Okay? If there is a genetic predisposition to not be able to get rid of those elements, let's say we have dysfunctional enzymes or dysfunctional proteins, those proteins are not getting rid of the metals the way they should,
that's when we get metal toxicities and buildups. That's when we now increase oxidative stress, and that's when we become more susceptible to a variety of disorders and disease conditions. Okay? Now, utensils. Unless you're using a copper leaching utensil, for which most of us don't, we're usually using some form of nickel or steel or some type of iron implement. Most of the time, utensils are not an issue. And
Copper pots.
now that's true. They're copper pots. They're copper pipes. All of those things can leach metals into our system, and once again, if we don't have the proper regulatory enzymes and proteins, that can build up in our systems and be a source of toxicity. The same thing for cadmium, by the way. And cadmium is far more toxic than mercury, folks. I need to let you know that. Okay, so cadmium sources can also prove to be a very big problem in dosages that don't have to be tremendously large. So really, when it comes to the most important variable that you've mentioned is probably environment. Whether you're talking about copper pipes, pots, exposures to certain elements like metals that may come from industrial areas, heavy industrial areas, tailpipe smoke from lots and lots of cars, fumes, and I hate to say this for some of you folks out there, but cigarette smoking own level of metals that are being produced in the system. So there are a lot of different sources, and it's a great question because there are so many environmental challenges that come to play, and we minimize them. But nonetheless, they can be very significant in individuals. Folks, these conditions typically don't happen because of one insult. They are usually the cumulative effects of multiple insults over time to an undisclosed, unbeknownst breaking point. In a simple way, we all have what I call biochemical armor. None of us knows exactly how strong that armor is or at what point it will crack. Everyone has a cracking point, but not everyone sees it. Some people go their entire lives, and that chemical armor is fully intact because they never came across the constellations of different or other insults that would produce the deficit in the armor that would cause a condition like schizophrenia to arise. Whereas other individuals don't have quite the solid biochemical armor, and successive hits up until age 15 to 26, boom, all of a sudden the last one is the trigger that starts the cascade going, and now we have a schizophrenia diagnosis. Okay.
Is it harder to treat patients with OCD and schizophrenia rather than just the schizophrenia?
That's a really good question, and I'm going to have to separate this into two different thoughts. Firstly, what we've seen is that OCD is typically an undermethylated construct. If it is truly OCD, now that's different from personality disorder. Most of the time, we tend to see more of that in overmethylation. Okay, so first of all, accurate diagnosis is very key. But once again, we're not treating diagnoses; we're treating the chemistry that underlies it. Okay, so if this person has the chemistries that produce symptoms of schizophrenia, is that obsessive component really a separate entity, or is it part of the entire phenomenon that that person is experiencing? Because certain individuals who, and let's go back to labels here, certain individuals who have schizophrenia have paranoia. Now, what is paranoia? It's oftentimes an obsessive version of cognitive focus that simply continually repeats itself. Okay, whether it is an obsession with the FBI, or if it's an obsession with radio-controlled frequencies and people from outer space or other planets or the television controlling us, all of these things are forms of obsessive thinking. So while we have actually described one as paranoia and the other condition is obsessive, now we could also ask, is this whole obsessive thing a positive, one of the formerly used terms, positive symptom or negative symptom of schizophrenia, is it one of those types of things where you might see it in individuals who don't carry that diagnosis? And I think really we have to stop looking at these things quite so separately. They could coexist, but not as those actual conditions of schizophrenia and OCD, more like an integrated part of a condition that's dysregulated. So looking at the chemistry and treating the chemistry is what it is that should show resolution. There are or the diagnosis OCD who are not schizophrenic, and they can do tremendously well on therapy. Okay, there are lots of people who have schizophrenia, and really you don't see obsessions as being a major part of the construct of what it is they do have. So I'd kind of like to tease that apart a little bit there, but at the same time really question, are these really separate diagnoses, or is the obsessive component really part of the underpinnings of that diagnosis of schizophrenia?
You mentioned a Canadian study that showed the long-term use of antipsychotics causing brain shrinkage, but you also mentioned that antipsychotics can serve as antioxidants. If a person is not on medication, would you recommend that they go on a low-level antipsychotic for a better outcome?
That is a brilliant question. It's a wonderful one, and you can't see me, but I'm chuckling a little bit here because I almost never recommend that somebody who is not on medication go on medication. Now, before all the psychiatrists out there jump on me, I want to say there's a caveat here. If the person is fairly stable and not quite erratic or harmful, or is somewhat managing to get along, and they're just those individuals who refuse to take medication. There are lots of those, okay? It's not my recommendation to necessarily start a medication because of the side effects. My first line approach is, let's start you on the nutrient therapy as soon as possible. Let's get you tested first. Let's do your history. Let's move through that process if you're stable. Now, I'm also a physician, and our first and foremost concern is the stability of the patient and their family. If a patient is controlled, if they're absolutely not positively moving in the right direction at that particular point in time, and nutrient therapy has not yet begun, then they do need immediate stabilization. We don't recommend the use of these medications for their antioxidant or supportive or antioxidative stress capacities. That was mentioned as a sidebar as to possibly why they might help while dealing with the neurotransmitter issue. In other words, another piece that may be positive for their utility. But no, we're not going to recommend those medications for antioxidant therapy. There are a tremendous number of really great antioxidants out there that can be used that are not pharmaceutically based and have tremendous benefit. So that's where we would go. We would look always at for antioxidant help, we would look more at the nutrient therapy. We would not look at the medications because they have horrible side effects, and no one wants to put anyone through that unless it is absolutely necessary.
Can undermethylation cause alcoholism in a schizophrenic?
Undermethylation does not cause alcoholism directly. However, any of you who've heard any of our other programs would have heard me say that undermethylation is actually part of the challenge that produces highly addictive capacities in individuals. Alcoholism is one of the results of this highly addictive capacity secondary to undermethylation. So is cigarette smoking, by the way. So is, I hate to put it this way, but the highly addictive capacity towards illegal drugs. For the folks out there listening, many people have wondered why some people can smoke cigarettes forever and just other people can only smoke one cigarette and they're hooked for life and they have a tremendously hard time breaking it. Well, the difference is methylation. Overmethylators, and those of you who've tested for overmethylation, I'm not saying go out and get yourself some cigarettes, some alcohol, and think you're going to stop tomorrow. That's not what we're saying. What we're saying is that the difference between the two types of people
is indeed methylation. Undermethylators tend to have highly addictive personalities. So trying anything that's illicit or inappropriate can lead to a lifelong struggle. Overmethylators tend not to have that particular capacity. Normal methylators, don't even think about it, okay? Just stay clear of everything. That's the safest way to go.
What your incapacity is to removing toxins. Incapacity is to removing toxins. So how do you know if your body is not removing toxins?
First of all, if it's significant, you're going to have symptoms of some type. That's why anyone typically goes to see a physician. The question is, I'm not working right somehow, some way. I'm either not thinking right, my body doesn't feel right, something's not right. Then there's the question of testing. The only real way to know if you're toxic is either to have a very strong constellation of symptoms that immediately direct a practitioner to saying you have either a cadmium toxicity, a lead toxicity, a mercury toxicity, one of those, or doing the tests that show that indeed you are toxic with some metal or some particular element. Okay, so it's really about symptoms together, because we have to be able to identify specifically what it is that's making you toxic. Otherwise, we can't really treat it.
Can your practice help someone determine specific nutritional deficiencies with CFS and depression and mood swings that is not diagnosed with schizophrenia?
That's a great question. I'd like you to repeat that, please.
Can your practice help someone determine specific nutritional deficiencies with CFS and depression and mood swings that does not have a diagnosis of schizophrenia?
Sure. Actually, there are a lot of diagnoses, well, there are a lot of symptomatologies that come from these particular disorders that have nothing to do with schizophrenia whatsoever. And that's because if you are a pyrroluric, if you are an undermethylator, if you are an overmethylator, there are a variety of symptoms that can be brought into play that may overlap with those that we've talked about, but they're not under the category of schizophrenia. And those nutritional imbalances that may or may not be present, or the toxic overloads of certain metals or certain gut issues, those things can indeed be evaluated. Yes.
How well are you able to work with the local psychiatrist regarding medication? Do you have to provide webinars, etc., for them before they believe you?
Well, that's a very interesting question. We have basically three types of psychiatrists that we encounter. Those who refuse to believe anything that anyone tells them outside of mainstream medicine, those who are somewhat curious but don't have the time, and then those who actually listen. And we've dealt with all of the above. One of the things I'm really happy to say is that many of the psychiatrists who have struggled with their patients' inability to improve are very well open to listening, especially when they hear that we're not telling them to stop the medication that they're using. Most of the time they'll say, okay, well, fine, go ahead and do whatever you want to do. I may not believe what you say, but if it's not going to hurt, knock your socks off. Go right ahead and do it. What becomes very pivotal, however, is when we're trying to communicate that because of the biochemistry of the patient, the medication selection or the medication choice could worsen their condition. That's when the conversations become serious. And what we do is we go back to basic biochemistry, molecular biology, and genetics in discussion. And we start talking about things at a level that really revolves around the in-depth analysis of receptor sites, activity at those receptor sites, what those medications will do, and how those medications affect the actual biochemistry of the patient. So we become highly technical with the psychiatrists at that point. And so they can see in a language that they understand the true nature of what they're doing and why it might be detrimental. Because most of the time these psychiatrists have seen similar reactions in other patients, but didn't know why those reactions occurred. And so this helps to bridge the gap. So when they can see that this is something that they can apply to future patients, they tend to be very, very happy to discuss those situations with us.
Mm-hmm. I'm getting a lot of questions on where our clinic is located and where you can be seen for treatment. And I want to mention to you all that Mensah Medical, Dr. Albert Mensah, he's the co-founder and president, and his colleague, Dr. Judith Bowman, their practice is just outside of Chicago, Illinois. And they travel throughout the year to select cities for our U.S. outreach in Northern and Southern California, Garden Grove, Burlingame, and they travel to Annapolis, Maryland, and Scottsdale, Arizona. Now, if you're not near any of these outreach locations, please feel free to email me at dana@mensahmedical.com, and I would be happy to provide you with some additional options for treatment, and we can look at other practitioners if need be in your local area. And we're going to take some more questions. We won't be able to get to all of your questions tonight. We're getting we're getting hundreds of questions actually tonight. So if we didn't get to your question, you can always email me, and we can try to follow up with you in email if Dr. Mensah can't address it tonight. That's a good idea. Very good idea.
Because of the nature of all the questions that have been asked, I just discussed with Dana the very significant possibility that we can hold a second webinar simply to answer questions from this particular webinar because of the huge volume of questions that we're getting. We want to try to get to everyone's concerns because this is such an important topic. And as I said, this is actually the topic that really sort of solidified me in this field in terms of my belief in this process and truly the miracles that we saw. Now that we understand the science behind it, it's less miraculous. But for somebody who was quite the disbeliever in this whole kind of therapy, that's a very huge statement for us, or for me in particular. Next question.
Next question. Can you give me a shorter answer as to why I'm depressed but cannot tolerate SSRIs? I have horrible side effects. Would there most likely be a genetic answer?
The answer is that you might be overmethylated. Very simple. Individuals who are overmethylated have a tremendously poor response to SSRIs. And for those of you who are neurotransmitter focused, what happens with overmethylation is that you tend to have high levels of serotonin, dopamine, and norepinephrine. And when you give it an SSRI, you're now adding insult to injury by increasing far more the level of serotonin, and this causes individuals to experience extremely horrific reactions. On a parallel side, individuals with who have bad reactions are oftentimes individuals who have low levels of histamine, and those SSRIs further suppress histamine. They're antihistaminic, and so that plunges them at a different level into the abyss of unwellness because of medication. So it may be one of two things. It could be either your methylation or it could be your histamine chemistry.
My son was evaluated by you in 2007. Has the testing changed much since then?
2007. Actually, I would say our process has evolved since that point in time quite a bit. We've reformulated some elements that were present. We've moved from the idea of simply biochemical imbalances to what we call comprehensive medicine. When we put together this clinic, I sort of assessed where we really stood in the world relative to how we approach things. And in our old clinic facility back in 2007, we treated biochemical imbalances. And I said, when we started this clinic, this is not the right conditions. We have to let people know that there is truly a bridging piece between the gap of orthomolecular medicine and traditional medicine. So we call ourselves comprehensive medicine. We look at all aspects of a person's condition, from diabetes to hypertension, and how all those things affect the nutrient therapy, how they're affecting the patient, So we understand now the pros and cons, the challenges, and the positive blessings for even helping to support other physical manifestations of disease and not just the cognitive ones. So we're looking at both pieces, and we call it comprehensive medicine. We don't call ourselves alternative medicine because really this stuff is there in its grassroots in traditional medicine. They simply have not looked at the flowers that are growing from those roots. They simply ignore them because they don't know any. Bridge that gap. And yes, indeed, the basic testing is fairly much the same, but there are other elements that we're now spending more time looking over and assessing than we did previously. And I hope your son is doing well, by the way.
Back to the previous question before that. So you can be depressed if you have high serotonin levels. I'm confused.
Yes.
Yeah, too much.
Absolutely.
Much serotonin.
Too much serotonin is exactly what happens in overmethylators. And overmethylators can be depressed, whether they have schizophrenia or as a diagnosis or not. In fact, they can be horrifically depressed. These are the individuals who can become homicidal or suicidal if given an SSRI antidepressant, because they are normally running on extremely high levels of serotonin, dopamine, and norepinephrine anyway. So even the atypicals, not the atypical antipsychotics, but the serotonin and norepinephrine reuptake inhibitors, the newer classes of these medications, can produce severe damage in these individuals who are overmethylated if their chemistry is not known when they are given these medications. Across the United States, we've all heard of these mass shootings in school systems by young people. And Dr. Walsh has literally assessed these situations of 18 out of the 20, and it turns out 18 out of the 20 individuals who hauled off and shot all these people, these kids, were individuals who had started pharmaceutical medications less than 3 weeks before the shooting. And Dr. Walsh's belief and understanding is that these individuals were over-methylated people, and their methylation status interacting with the medications is what pushed them over.
And this is not really known in mainstream psychiatry. It's just, what do I want to say?
It's orthomolecular.
It's orthomolecular. So, yes, it's the common misconception is that depression is low serotonin. So thank you for asking that.
Yes. And that's why it is that some medications work for some people with depression, and those same medications don't work in other people. It's because of biochemical individuality. And actually, we had a webinar on that. So if you want to take a look at those slides and so forth, or view the webinar, you can certainly do so online.
Mm-hmm. Any connection between SIBO, small intestinal bacterial overgrowth, and any one of the in particular?
I'm pausing because I'm literally going through sort of all the permutations and combinations with all the different bacteria that I can think of along those lines. Typically not from the perspective of a direct neurotransmitter influence or a direct methylation influence, but we talked about oxidative stress. Now, anytime you've got a gut challenge or dysbiosis in especially a young child, or even in certain older individuals, that can produce inflammation. That can produce oxidative stress. And remember, we talked about these disorders being disorders that are sensitive to oxidative stress. So while I'm saying I'm not affect the overall condition of the patient, whether we're talking about methylation or under or over methylation, they're not directly affecting those things, but they can cause oxidative stress, which can lead to pyroluria. And pyroluria can be a predisposing variable for various disorders, including schizophrenia. Now, don't get me wrong. I'm not saying the gut is the cause of schizophrenia. I don't want anyone sending us emails saying that I said that. That's not what I'm saying. It can be a contributor to a lack of healing or a worsening of symptomatologies. And that's what I'll say about that.
Mm-hmm. This question is going along the lines of this. My husband was diagnosed with schizophrenia since 7 years now. He also has asthma and often gets gastric troubles. These gastric problems often put. How do I handle this?
Oh, interesting, interesting. The question is really, is there yet another mechanism that may be involved in this individual's diagnosis? Whenever we have bowel challenges like that, where we hear that somebody has a severe reaction after eating in general, and it's not any particular foodstuffs, the question about a genetic deficiency in the production of an enzyme called diamine oxidase. It's an enzyme that is meant to actually break down histamine in foods. Some individuals are actually deficient in these enzymes or in this enzyme, and it can cause very strong discomfort and reactions in folks who typically are consuming histamine-rich foods. So one is food avoidance, but the other is there's actually testing for this enzyme, and taking this enzyme resolves a lot of these particular issues. But this particular person with a history of asthma, with a history of all the things that are mentioned, also sounds like an undermethylator. And that's just from history alone. Of course, a lot more history needs to be taken in order to make those kind of presumptions, and then testing must confirm it. But one area where somebody may want to look is with regard to the type of enzymes that are present in this individual, whether or not there's a diamine oxidase dysfunction or shortage.
Can alcohol and drugs in the blood of a schizophrenic affect test results?
No. Easy question, easy answer. No.
With a family history of Alzheimer's and multiple environmental allergies, would you recommend the person investigate methylation disorders?
Yes. We know that Alzheimer's is actually very well correlated and high methylators. So absolutely, testing would be a good thing for family members.
Now, what about a person with breast cancer and chemotherapy, otherwise healthy now at the age of 75? Would you recommend the person investigate methylation?
Actually, yes. Primarily because now this is a Mensah Medical protocol here. We've come to see and understand now that methylation actually protects against cancer gene expression. Methyl is a protective variable against cancer genes. So if someone is undermethylated, it means that in certain types of cancers, they're going to be actually more susceptible to developing that cancer, or more susceptible to the insults that can cause the expression of that cancer gene. Also in a female, we've got to be concerned once again about copper, because copper not only is a pro-inflammatory condition, not only does it cause oxidative stress, which leads to cellular damage. Cellular damage and inflammation are often key elements that help allow cancer to develop. But now if you combine an undermethylated situation with high copper, now you're talking major league trouble. While patients, and I'm not trying to scare anyone out there, but my concern is, I can just tell you personally, I've lost 2 colleagues from medical school, young in life, to breast cancer. So when we came across this information and we started thinking about it, we had to do something in terms of protocols and procedures. So it is now my personal challenge when I find out, or even if the question comes up about cancer, that I provide this information. Even though you're 75, you're doing well, we're happy, we're pleased. It doesn't hurt to find out what your methylation status is and to look at what your copper levels are. Okay? It doesn't hurt. And some things can actually be done to help support you such that we want to minimize the risk. I'm not saying eradicate the risk, but minimize the risk of that cancer returning.
How would you recommend? Would you recommend to just try out Dr. Abram Hoffer's niacin treatment
No.
for a schizophrenic who refuses to do any testing?
No, I would not recommend that. I guess, and I'm kind of chuckling here because you're a very astute person, whoever it is that came up with that question. This person recognized the propensity for most of the people with this diagnosis, the 42%, to be overmethylated, and therefore, statistically, if you're going to have any benefit, niacin or niacinamide would be the way to go. The problem is that you don't know dosages, okay, number one. Those elements can become toxic. Each one of the nutrients that's used has several different uses and can have some very specific points at which you simply do not want to use them for other reasons. Remember, we talked about the idea of comprehensive medicine. Well, we're looking not only at the schizophrenia, we're not looking only at the chemistry, we're looking at everything that's involved in that patient's life. And now, you know, if dopamine is not the issue in this particular person, then, you know, what are we saying here? Are we going to risk upregulating everything else at the, just because we're kind of, I hate to use the term, but desperate in a way to try to get them some help? Okay. I know it's a very, very hard phenomenon, but we have to be careful because we really do need the guidance of testing first. And somehow, somewhere, you know, a lot of people have been very creative about how they go about getting that testing done, but I know it's a hard process, but we can't sort of change the entire phenomenon circumstantially. We still need to have testing, and we still need to have appropriate history to really sort of make the right recommendations, because the wrong move in the wrong direction can make a patient far worse. So.
How do you actually determine if the imbalance is an epigenetic phenomenon?
Sorry, I had to get a glass of water here. Dr. Walsh has already assessed and continues to assess through his research elements that have an epigenetic focus versus conditions that have a genetic focus versus conditions that are neither genetic nor epigenetic. So we actually have a list of disorders that we know are epigenetic in nature. And that list is growing, not just with Dr. Walsh's research, but with research from all over the world, and research from several other specialties in medicine. One of the largest and rapidly growing fields of medicine that delineates epigenetic mechanisms, especially with methylation disorders, is actually in cancer research. That's why I kind of talked about cancer the way I did, because we learned so much about epigenetics from very early studies in cancer research. Now, these early studies, I mean the ones that are talking about epigenetic methylation challenges, and those are fairly recent, within the past 5 to 7 years, and they've told us a tremendous amount. So we're learning more and more through several different fields of medicine about many disorders that may be epigenetic in nature versus those are genetic.
Do you recommend to test siblings of schizophrenics in families for methylation?
You know, that's a great question. And I only hesitate because I'm fighting against my own mantra, which is, typically speaking, if it's not broken, don't worry about it. However, we know that there's a concordance rate amongst siblings and family members of schizophrenics. And so it really might be a good idea to at least get tested to know whether or not there's a certain risk. Well, I should actually say to kind of look at the potentials for similar chemistries producing similar situations. But remember that that risk is not necessarily greater than 50 or 60%. And I know 60% sounds like a lot, but let's just say even in twin studies, the concordance rate is somewhere around 50% or slightly less. So we could say you could use your own judgment on that, but we do know that family members tend to have a higher risk of recurrence than non-family members. So I would certainly say there is that risk, I would consider testing, and certainly if you see any strange symptomatologies happening with family members, I would definitely not waste any time and get them tested. It might not be schizophrenia, it might be some other manifestation of an epigenetic disorder related to methylation or otherwise. But nonetheless, that person should be evaluated right away.
Mm-hmm. Will treating undermethylation improve addictions?
That's a great question. And we've actually done work on that. There's a good part and a bad part to this, or rather a good part and a sad part to this. The good part is, yes, it can. However, here's the challenge. The given individual has to typically stay away from that particular substance for at least a month to 2 months while the treatment is in progress. And that's the hard part. So we know we can help, but it requires basically abstinence from whatever that condition is in order to break the cycle on a more permanent level of that addictive process. Okay.
Mm-hmm. If a 6-year-old has neurotransmitters firing too high in the 85 to 100% reference range, is there a methylation explanation or pattern to look for to understand what is causing aggression?
Maybe. The question is it even a methylation disorder that's causing the aggression? The aggression could be caused by, now here's the thing, children are not miniature adults. Children have gut issues. They typically don't have a very solid gut until much later in life. So they're often stressed with leaky gut syndrome, as you've heard in our discussions with regard to autism. They're stuck with inflammation. They're often yeast overloaded, which can provide for a functional malabsorption and therefore nutrient deficiencies and therefore imbalances that can translate to behavioral challenges. They can also be metal toxic. They can also be, they can also have a variety of different elements that can lead to behavioral disorders. Okay, so if there's a child that's having a very extreme behavioral pattern, one of the first things I would actually do is a gut evaluation, and I would check them for yeast. And I've talked about this particular case before, we've known children who were thrown out of preschools, 3 or 4 different preschools, before the age of 4. And they were evaluated by mainstream medicine, and they couldn't find anything going on, neurotransmitters, otherwise, et cetera, et cetera. We found out that these kids were just yeast toxic. And after the yeast was treated, these children were perfectly fine, doing extremely well in school. Gut dysbiosis, fecal impaction, in other words, being constipated, as my partner would say, my business partner, Dr. Bowman, she would say if you're packed to the rafters, that produces behavioral challenges in children as well. So there's a very different approach to dealing with children and behavior disorders that extends beyond nutrient therapy purely and the discussion of biochemical imbalances, but is certainly inclusive of them. Okay, all those things are possible. It's not simply about neurotransmitters firing rapidly or firing whatever. The question is, if that's true, why is it true? Okay, and that's what we look for, the underlying imbalances there, the underlying causes.
Is there a specific type of schizophrenia that is induced by drugs? How would you treat drug-induced schizophrenia?
That's an excellent question. And for those individuals, certainly, depending on the drug and the cause, we have to be careful about prognosis. Okay. There are certain drugs, especially the hallucinogens, that make it very difficult to look at a permanent resolution. There are other drugs that, when removed, all that needs to be done is sort of repair work and antioxidant or oxidative stress inhibiting mechanisms that can bring that person back to a more normalized state or condition. So it really depends on the particular drug in question, the length of time of usage, and the intensity of the effects of that drug. Did that drug, for example, destroy receptor sites in the brain? You know, LSD, PCP, these are elements that literally destroy receptors, and you'll wipe out with just one trial of ecstasy, for example, the majority of serotonin receptors in the brain. And so coming back from that is going to be extremely hard to do, extremely hard. And actually that has a poorer prognosis, to be quite honest. But so it really depends on the drug, length of time of usage, effect in terms of how the chemistry of the brain has actually been shifted, and whether or not there's been actually neural damage.
I forget if you've addressed this question or not, but it's a good one. Why does pyrrole have the best prognosis? Also, does starting treatment with an inhibitor so greatly help as far as prognosis with all major biotypes?
Well, the one thing I enjoy about seeing an individual who has this diagnosis of schizophrenia is that it doesn't matter how long they've had it. They can be 40 years old, 50 years old, 60 years old. They can still do significantly well. That I want to share with you. Unlike autism, where you want to try to catch them, certainly before the age of 16, and the earlier you see them, the better they'll do. Schizophrenia is a different condition altogether. So when we're talking about timing of improvement, age is not so much an issue. The concept of pyroluria as a foundational construct for schizophrenic type symptoms is really one of a loss of certain nutrients that, when replaced, create the rebalancing effect for a lot of the biochemical dominoes that were knocked down. And that can happen very quickly. It's simply a matter of the actual physiological mechanism of restoration. It's just faster in pyrolurics. With regard to, that's more of a molecular phenomenon. Methylation syndromes tend to be more of an epigenetic construct. So when you're dealing with the blueprint of DNA, it takes much longer to shift what is an ingrained epigenetic DNA pressed down concrete functional process than it does to treat a molecular biochemical one. So we're talking about genes and genetic production of proteins here, and the disarray that's present with under and overmethylation. Those are the elements that are hardwired into genetic expression. So that's why it takes much longer for each one of them to be addressed when we're talking about nutrient therapy as far as resolution or improvement is concerned. Okay? It's about dealing with the genes.
Is there a connection between undermethylation and behavioral addictions?
Yes, we actually kind of talked about that. Well, behavioral addictions.
Yeah, behavioral. I'm not sure what they meant by that.
Well, I'll say that if behavioral addictions, if we're talking about obsessions, then I can say quite certainly many obsessions are seen in undermethylated individuals. Things like hand washing and all those performance things you do, the compulsion aspect. Yes, those things can indeed be associated with methylation. If you're talking about things like, once again, alcohol and drugs, yes, indeed, once again, they can be associated with methylation. So I guess we could say the answer is yes.
Okay.
We have to take just a couple more questions.
Okay, we're just going to take a couple more questions here and wrap this up. Do cluster personality types fit into the methylation theory grading of psychiatric illnesses? Would these be axis 2 disorders?
That's an excellent question. And we've not truly assessed the cluster disorders to really give you sort of that definitive question, so the definitive answer. So I really could not give you a very firm and confident answer on that one. We've not assessed them. When we talk about different disorders, we're really looking at our statistical evidence and the research that's been done here behind those things, and we've not really assessed the cluster elements.
Explain the methyl folate ratio, please.
The methylfolate ratio. Trying to think of the shortest way to put this. Okay, when we're talking about the effects in the environment of the womb, literally between day 16 and 21, when methylation challenges are most sensitively capable of affecting a developing individual. And even beyond that time, by the way, it's not simply an insult, it is about the proportional concentrations of methyl groups, and this is biochemistry, folks, and chemistry. It's about methyl groups and what percentages there are relative to folate groups, relative to molecules called acetyl groups, relative to phosphate groups, and a variety of other groups. Now, this ratio is kind of like that tug of war we talked about earlier. That tug of war determines who gets to affect the DNA. If you've got a higher amount of methyl than folate, then certain parts of the DNA, that is the wound up, balled up, curled up DNA histone, may be protected and it doesn't open up and it doesn't become susceptible to what we'll call environmental genetic terrorism, okay? Where you get the wrong influence on the DNA leading to the wrong production of the wrong proteins, enzymes, and neurotransmitters. It's the balance between the two. It's like a tug of war. That's what the methyl-folate ratio is. You can have higher methyl or you can have higher folate. And each one of those things, if one is higher and one is lower, each one can actually cause a different effect on the DNA itself in terms of what we call expression, or the genetic machinery that's now going to produce proteins and enzymes based upon a blueprint that may or may not be correct as a reading of the original design. So methyl-folate ratios can actually taint the blueprint of genetics. And so the body's machinery will misread it and produce the wrong proteins. So that's what the methyl-folate ratio is about. It's really the contest between concentrations of methyl groups and folate groups. But I want you to understand also, they're not the only two groups involved in this discussion of DNA and protein development and so forth. Once again, there are groups called acetyl groups, phosphate groups, and a variety of other groups involved in this process that are all competing, so to speak. So that's one of the reasons why you don't really want to take large concentrations of supplements on your own without being tested and guided in this process. We're not talking about simple nutrients here, even though the topic of this discussion is nutrient therapy and nutrient power. We're talking about how we're literally affecting DNA molecules. So, folks, that's not one for you guys just sitting at home. Okay, that has to be done by really a physician here. Okay.
Thank you. I think that wraps up our discussion for tonight. If we didn't get a chance to answer your questions, please feel free to email me at dana@mensahmedical.com, and I can share them with Dr. Mensah. And this webinar was recorded tonight, so if you would like to re-watch it or share it with a family member or loved one, it will be available on our website sometime next week at mensahmedical.com under Video Library. And if anyone would like a copy of the slides or the PowerPoint presentation, I would be happy to email them to you as well. Thank you so much for joining us, and good evening. Good night.